Good evening. Welcome to the second lecture in the 2012 series, Global Diseases, Voices from the Vanguard. As I think most of you know, Voices from the Vanguard is a joint effort between the Center for Tropical and Emerging Global Diseases and the Knight Chair in Health and Medical Journalism, Professor Pat Thomas, of the Grady College of Journalism and Mass Communication. So thank you for coming this evening. I think you're in for a real treat. But before I introduce tonight's speaker, let me remind you that directly following the talk tonight, there will be a reception in Demosthenian Hall right next door. And also, looking ahead, I hope that you will remember that our next Voices from the Vanguard lecture will be on March 20th, when we will host Dr. Mark LaForce, and he'll be speaking on the meningitis vaccine project, which is an exciting joint effort between the Bill and Melinda Gates Foundation and the World Health Organization. And so that will be on the 20th of March. Whoops, no, restart later. Okay, now on to tonight. Soon you're going to learn about how to allow millions of people to visualize the world around them. Unfortunately, millions of people do not have the eyesight that lets most of us enjoy the visual pleasures of this world or pursue fully their talents because they're blind. Tonight's speaker, Dr. Sheila West, is a leader in the drive to prevent the global scourge of blindness. Dr. West is the El Magabi Professor of Preventive Ophthalmology in the Dana Center for Preventive Ophthalmology, a part of the Wilmer Eye Institute at the Johns Hopkins University. She's studied a wide variety of causes of blindness and has used the knowledge she's gained and her worldwide experience to be a leader in doing something about preventable blindness. Sheila has published over 200 scientific papers on a wide range of topics pertaining to the epidemiology of vision. That's ranging from the risk factors for cataracts in minority populations in the US to vision and its relationship to function in the elderly, especially in regard to driving skills. However, her focus tonight is on how to actually prevent blindness in large populations. And that has to do with the bacterial infection Trachoma. Sheila earned her PhD degree in epidemiology from the Johns Hopkins School of Hygiene and Public Health, and from there went on to become a full professor in the same institution. She's had overseas projects in the Philippines, Ethiopia, Nigeria, the Gambia, and a long-standing program in the Kongwa Trachoma project in Tanzania. She's received numerous awards and honors and is currently the director of PRET, which stands for the Partnership for Rapid Elimination of Trachoma, a Bill and Melinda Gates Foundation-sponsored program asking very practical questions on how to best achieve the elimination of blinding trachoma, the leading cause of infectious blindness. Please join me in welcoming Sheila West, a true leader in the fight against preventable blindness across the world. Sheila. Thank you.
Thank you, Dan, and thank you for the opportunity to come to this lovely campus. I've had such an exciting day with you and your group, meeting everyone from someone who is just so excited about applying bioinformatics to malaria, to a young student who wants to figure out how to do GPS and GIS studies in infectious disease. So it's been a wonderful day. So I'm going to talk to you about my absolutely favorite topic, which is elimination of blinding trachoma. We have a target by the year 2020, and that has special significance to those of us in ophthalmology, 2020, of course, being ideal vision. So I'm going to start right off with what is our goal? What do we want to do? And the World Health Organization and its consortium partners is looking at eliminating blinding trachoma by 2020, translated as these ultimate intervention goals. We mean trachoma less than 5% in young children at a subdistrict level, and trichiasis, which I'm going to tell you what that is in a minute, unknown and unoperated, less than about 1 per 1,000 population. So that's what we're trying to do. Now, in order to achieve those goals, you need to understand a little bit about the disease and the challenges we face with it. So I'm going to tell you about the organism, about the clinical disease, about the epidemiology, and where we are now. And that's what we're going to go through in the next hour or so. So let's start off with the pathogen, Chlamydia trachomatis. And when I usually say that in lectures, everybody goes, well, wait a minute, that's an STD. What do you mean, the eye? Well, for most of the world, it actually is an ocular infection as well as an STD. And in this slide here, you can see my colleague in Tanzania taking a swab of the upper conjunctiva. You know how when you're kids, like kindergarten, you can flip your own eyelid and gross your mom out? Well, that's where chlamydia hides, is up in that upper eyelid. And if you take a swab, and in this case it's direct fluorescent antibody test, you can see all these little chlamydia in that slide. So what is it about this pathogen? Well, trachoma is caused by repeated, and I stress repeated, episodes of infection with Chlamydia trachomatis. So one infection, as you might see, for example, with a baby born to an infected mother, does not trachoma make. You need that repeated episodes to get the kind of picture of trachoma that I'm going to show you. Chlamydia comes as 3 biovars. 2 of them cause human disease. Trachoma biovar, and that is serovars A through K, and lymphogranuloma venereum, an STD, which is L1 through L3. Now, the interesting thing here is that the ocular strains are A, B, and C. Actually, we know are very different than the strains, which are D through K, that cause sexually transmitted infection. Why? Because the ocular strains carry a frame shift mutation in the gene encoding tryptophan synthesis, such that the ocular strains cannot use exogenous indole to synthesize tryptophan. Now, why does that matter? Well, because that's one of the ways that the host tries to limit the infection, is limit their accessibility to this particular compound. However, in the genital tract, particularly in the vagina, there's a lot of indole around, and so genital chlamydia strains can use that exogenous indole to synthesize tryptophan and get around that defense mechanism. There's no such indole in the eye, so the ocular strains have never developed that capacity. So there is tropism from the different serovars to the different tissues. The genome of serovar D and now B have been sequenced. We know that chlamydia is an intracellular organism largely because it is unable to synthesize ATP. It needs the host cells in order to do that. So it's a very, very interesting organism. This shows you the life cycle of chlamydia. And there's a couple of things to note. First of all, there's 2 very distinct phases. One of them, there we go, is the elementary body phase. This phase is when the organism is infectious, meaning it can infect cells, but it can't divide. But once it gets inside the cell, then it starts changing, it reorganizes its DNA, it changes into what we call a reticulate body. The reticulate body is now capable of dividing, but it's not infectious. If that cell were to burst and release reticulate bodies, nothing else would happen. But notice what happens over time. It grows inside this inclusion, gradually filling the cell. About 24 hours after infection, they start turning back into elementary bodies. At about between 40 and 48 hours or so, the cell inclusion bursts, releases all these elementary bodies, and the cycle starts over again. So why is that important? Well, look at the long time frame. It's almost 48 hours between the time of infection till that's released again. Meanwhile, this thing is sitting inside a cell, hidden. So you need to treat it with an antibiotic that's got good intracellular levels and for a pretty long period of time to be effective against this bug. So and there's a lot of interesting dynamics and potential for interrupting this cycle. That's a topic of basic science that we won't go into here. So what happens with infection? Well, it targets epithelial cells. It infects the conjunctiva, as I said, but it also affects anywhere there's an epithelial cell, genital tract, respiratory tract, intestinal tract. There are exogenous factors that prolong the life cycle, and in cell cultures, we've noted persistent, latent infections that we would love to know if that happens in actually human hosts. But it suggests that chlamydia can persist for quite a long time in a latent stage. There are a number of epitopes being studied for vaccines, and we'll talk about that in a little bit. The primary immunologic mechanism for control with infection are both neutralizing antibodies, cytokines, and then CD4 plus T cells. Unfortunately, we now know that the neutralizing antibodies are not terribly effective, except in cell culture, but not in human hosts, as you might expect, because people get this infection over and over and over again, even with the same serovar. Well, trachoma has been known since ancient times. For all of you who read hieroglyphics, this actually tells you about treating trachoma among ancient Egyptians. Some pretty bizarre and actually very frightening treatments have been advanced for trachoma. In this case, this is an old method taught by the Greeks that take what look like sort of eyebrow tweezers and tweeze these follicles out. The result, of course, is just simply that you make scarring worse and that you spread infection. But since the 1920s, we've known that there's something about it that is transmitted person to person. And in this very old textbook talked about how people shouldn't share towels, shouldn't share bed clothings in an effort to reduce transmission. So what does it look like clinically? What do we see when we see trachoma? So for those of you that are non-ophthalmologists, here's this eyelid flipped, and it's very nice looking. No inflammation. You can see all this nice, deep vasculature, a very normal-looking eye. Now, if you go to Tanzania and you take a look at a child like this, 8 months old, and flip his eyelid, you will see a very different story. And by the way, this burn mark up here that you see is a traditional medicine approach to controlling blindness in this area, that if you put a burn mark and get a scar for this child will not go blind in later life. That's how common blindness is in these villages. So we flip this eyelid, and what do you see? Something very different. Well, at least I can on the computer, but what you see are these white follicles, these germinal centers filled with B lymphocytes that are pathognomonic for trachoma. And often you see very severe infection, lots of inflammation, red, swollen, and again, these follicles in an eye like this. And you see this largely in preschool children up to about age 7 or so. Now, what about the mother of this child? The mother who has lived in a village, grown up with repeated infection over and over again. If you flip her eyelid, you see something like this, where instead of the normal vasculature, you see this basket weave of scarring, where you've got fibrous tissue replacing the normal conjunctiva, the result of repeated infection over time. And with any kind of scarring, as you know, when you get a cut, you feel that kind of contraction, the skin gets very tight. Same thing happens with the eyelid. Instead of a normal eyelid pointing out, you get contraction that pulls the eyelashes down across the cornea, and you get what we call trichiasis. And you see this eye, where you see trichiasis and eyelashes turning under, scraping across the cornea. You've got loss of your normal conjunctival architecture, and eventually you see corneal opacity, eyes that are permanently blind from trachoma. These eyes are not amenable to corneal transplant, and they are lost. So this is what we're trying to prevent, the end stage of trachoma. And in fact, the eyelashes turned under are so common that women in these areas will wear tweezers as jewelry in an effort to pluck out their own eyelashes or those of their friends. So let's go back here. We've talked about this cycle, transmission over and over again, scarring, trichiasis, and blindness. So let's talk about a little bit about how do we look in a community for trachoma. Well, as you might imagine, there's two ways. We detect infection and we look for clinical disease. However, the correlation between the two is actually not as optimal as we would like to see. The follicular reaction you saw, those follicles, takes quite a long time to resolve. And if you go in cross-sectionally into communities, about 46% of those who have clinical disease will not have any evidence of infection. We do see preclinical infections in about 4, maybe as high as 24% of the population. They're largely incubating disease at that point. And in adults, sometimes we will see positive cases of infection, but they never show any clinical signs. So right now we are left with PCR tests for chlamydia DNA in the plasmid. Plasmid reside inside the chlamydia. It's more sensitive than culture, but it costs about $10 to $15 per test. So if we could even do a PCR test in many of these countries. So we don't have a very good lab test for chlamydia at present, and we rely on clinical signs. And you'll see a little bit later on why that can be problematic. Here's an example from one village where we had a lot of disease, about 75% of kids with trachoma. And you can see right after treatment that we dropped infection pretty drastically down to about 20% from about 70%. But look what happened to clinical disease. Really not very much at this point. So if you're a program person monitoring clinical disease and you go to all the trouble of treating and you see, wow, I got down to 50%, it's ignoring the fact that your load of infection actually went quite a ways down. So this is one of the real challenges, is how do we monitor how well we're doing, since the antibiotic is treating infection and we're left monitoring disease. Well, let's look at the epidemiology. So if I go into a community and I say, cross-sectionally, what do I see in this community? Here's what you're going to see. Here is active trachoma. Here's the clinical disease. Peaks in kids at preschool, rapidly drops off. There's still some active disease in this age group, largely in women. But at the same time, we start to see scarring, and scarring goes up after about age 25 or so. You still see some in children, and trichiasis goes along with it. So in a typical community, we see a lot of trachoma, active trachoma in kids. We see the problem of these interned eyelashes and corneal opacity in older age groups in a community. Well, trachoma, as Dan intimated, is really a serious public health problem. We've got about 3 to 7 million blind people or severely visually impaired people already. 40 million people worldwide are in need of treatment now. Scarring and trichiasis are actually much more common in women than men, so this is a disease of children and of women. And it constitutes about 5% of the global burden of blindness. It's currently endemic in 55 countries that we know of, and we need data from at least 10 more countries to confirm whether or not it's a problem there. So there's still a lot of work to be done. Here's the global distribution. It probably looks like the global distribution of most of the NTDs. There are foci still left in Latin America, but largely the burden is in Africa. By the way, not all of Australia. This is a WHO map. It is still a problem among the Australian Aboriginal communities, but certainly not the whole of. And we don't know how big a problem in India or China, and that could be a real game changer once we get data in those countries. But lest you think it was only a problem in the developing world, this is a picture taken directly from the archives at Ellis Island of an immigration officer screening people coming into the U.S. for trachoma. At one point in the U.S., 80% of the U.S. Public Health Service budget went to screening for trachoma in this country. Of course, it wasn't very effective because trachoma was already here, and there were a lot of political reasons to turn people back if they had any sign of trachoma. But still, it was deemed an important public health problem and largely disappeared by the 1920s, before antibiotics, with the advent of socioeconomic change. So here's our famous slide again, transmission all the way, repeated infection, scarring, with some intervention points that we're going to talk about. Ways to interrupt transmission with hygiene, surgery at this point to avoid blindness, and of course, drug therapy. So back to our ultimate intervention goals. We want trachoma less than 5%. So what do? Well, we have this kind of odd guideline that we provide mass treatment of districts and subdistricts where trachoma is greater than 10%, leaving the districts that are between 5 and 9% kind of hanging with no idea what they're supposed to be doing. I'm glad your computer is on top of the need for updates. And trichiasis, less than 1 per 1,000 population, where it's no longer considered a public health problem. So we have quite a surgery load to consider to make our trichiasis that low in any one country, and quite a burden to get trachoma less than 5%. So the World Health Organization has come up with a multifaceted strategy for the control of trachoma called SAFE as an acronym, and it stands for surgery to reposition those eyelashes away from the cornea, antibiotics to reduce the community pool of infection, face washing and environmental change to interrupt and reduce transmission. I like to think of it more as kind of surgery to really deal with the late complications of trachoma, and AF&E that targets active trachoma by reducing the community pool of infection and transmission so that you don't get a cohort of people that need surgery later in life. So we're going to talk about each one of these going forward and some of the challenges. And I'm going to start with surgery. Now this is a really interesting picture, isn't it? This is trichiasis surgery being done, but not by an ophthalmologist, by an eye nurse, and not in a hospital. It's being done in a village and being done using very primitive tools that are quite effective. So we know that this relatively simple procedure, bilamellar tarsal rotation, is beneficial in alleviating trichiasis, and it can be performed acceptably by eye nurses or integrated eye care workers, and it could be carried out in the village. So problem solved. Seems pretty straightforward. However, we see a very low uptake by the community of trichiasis surgery services. Less than 30% of cases that we followed over a 7-year period ever came to surgery, even when we offered the surgery free, even when we provided transportation. So I'm going to come back to that because that's a really significant problem. So you say, well, maybe the surgery isn't any good. Well, here's some data to suggest what happens to people who have surgery. First of all, people coming into surgery complain a lot. They've got pain from these eyelashes rubbing their eyes. They actually have a lot of difficulty seeing, particularly in bright sunlight, and you can get rid of that with surgery. You can actually improve vision, something we didn't expect to see. People gain about a line of vision. If you think back to when you got your eyes tested and you had to read that acuity chart, they can actually read an additional line post-surgery, which, since you're only correcting eyelashes, is really a very exciting finding, and one that several of us have reported now. So we went back to people and said, here's the good news. So what can we do to enable you to have surgery? And there were a variety of reasons that people gave. They wanted somebody to come with them. We needed money for surgery. We need to know if we have a caretaker for our children, etc. But 52% of people said, there is nothing that you could say that would convince me to have this done. So there's a real need for more of behavior change kinds of approaches for our cases to find out what it is, and it's largely fear, is my suspicion, that would enable them to take up surgery. That's one part of it. The other part is that recurrence rate following surgery in program settings is actually really high. It's kind of a dirty little secret in all these programs that are going on that once you do surgery, within 2 to 3 years, 40% of your eyes are going to have trichiasis again. And so that begs the question of, well, maybe people are making rational decisions about whether or not they want to undergo something if their chance is 1 in 2 that it's going to come back again. So we undertook actually a study to figure out, could we avoid having recurrence if we used post-treatment antibiotic to try to control infection after surgery. And this was done in Ethiopia, in the southern part, where we enrolled 1,400 people randomized to azithromycin or topical tetracycline immediately post-op. Now, something you should know about topical tetracycline is that it takes about 4 to 6 weeks before it clears chlamydia. It's not a terribly effective choice, but it was the WHO recommendation. Zithromax, as you will hear, is a far better choice. And what we found was that using azithromycin, we were able to decrease by 1/3 the recurrence rate at 1 year following surgery. Now that in alone is very good news, but what really came out of this trial is that the recurrence rate, even in the tetracycline group, was about 10%. It wasn't 40%, it was 10%. And this is in a hyperendemic area in Ethiopia, so what on earth did we do that made this so low? Even out to 3 years, you can see that recurrence rate is around 13%. Very striking finding. So yeah, recurrence rates in hyperendemic areas can be low. Well, what we did was spend a lot of time on training and certifying surgeons so that the bad surgeons were not allowed to operate. In addition, we used antibiotics to reduce recurrence. So those 2 things together, training, certification, and antibiotic use, we think would go a long way to improving surgery for trichiasis in these countries. And as I said before, we need to be better stewards of the information we have that surgery done well can actually improve quality of life. So what are the challenges to meet the 2020 surgery? There was just a large WHO meeting in Tanzania to look at this question. We're going to need some kind of probably camp approach to clear the backlog of surgeries if we're going to meet our 2020 goal. We need 15,000 surgeries every year between now and 2020, just in Tanzania. And last year they did 1,400 to reach our goal. And as I said, we need improved outcomes. We need better training. I think we need the willingness for countries to say, you know what, you really shouldn't be a surgeon and not allow people who can't do it to be certified. And that would be helped a lot by surgical audit approaches. And I think we need ongoing research to figure out how can we improve outcomes. What are these surgeons not doing right that is leading to such bad results? So let's go on to the antibiotic component for trachoma. About 10 years ago, we had 2 choices. One, as I said, was topical tetracycline. It's given once or twice a day for about 4 to 6 weeks. Or we could give systemic azithromax in a single 1-gram dose. For those of us working with topical tetracycline, this was a no-brainer. I took this picture of a child receiving topical tetracycline, and I show it because it's the only child I have ever seen that isn't screaming having topical tetracycline in their eye. It stings, it really stings, I know, I've tried it. And it blurs your vision for like an hour because it's in an oil-based compound. whereas Zithromax, gets rid of your respiratory infection, controls your diarrhea disease, gets rid of your STD, and it works against trachoma. So it's just perceived as a wonder drug in these communities. So a couple of things that you should know about in treating trachoma. It's a community disease, so we've got to really focus on the community. We shouldn't be active case finding. You've seen the data. There are subclinical cases, incubating cases. So we offer mass treatment about once a year if follicular trachoma is greater than 10%. Now, the drug is donated. That's the most significant cost. But the cost of MDA is still between about 15 and 40 cents per person treated. So chalk that up to, what did I say? 40 million people that need treatment, and you get an idea what the cost of per year to do this could be. So here's the questions that we are still grappling with for trachoma. All right, we have to treat once a year, but for how long? How many years do we have to do that? We thought when we first got Zithromax, the company said it's 95% effective against chlamydia. Oh, good, maybe once or twice, and then we're done. Not the case, we know that now. And the corollary to that is, well, when can we stop? All we have is a clinical disease marker. What if we're still treating and all we've got is residual clinical disease and no infection? And if we stop, will it come back? There's the $24,000 question, because if it comes back, then we will never be able to have it eliminated. So let's take a look at some data against these questions. How long must we treat? So a couple of things we've learned. One is it depends on where you start. Interestingly enough, it's not as though you're going to get, if you start at 70% or you start at 30%, you're just going to end up at 2%. It really depends on the starting prevalence of disease and infection. And if you're at 30%, after one round, you're going to go to 15. If you're at 20%, after one round, you're going to go to 10. So it really does depend. And it depends on the surrounding district where you're treating. If you are treating the 10% villages that are the last mop-up, you can probably get away with 1 or 2 rounds of mass treatment. If you're treating the 10% villages that are just at the vanguard of elimination and the rest of the districts at 40%, that 10% is going to need every bit as much as the 40% villages. So here's some data from the Gambia, for example. As you can see, at the baseline, it was pretty low infection. There was one village that was about 15%, but most of them were about 5%. Right after treatment, all of them are down around 1 to 0%. But then right after treatment, 2 villages, the entire populations of these 2 villages went off to some big festival in Senegal where there was no treatment going on and got horridly infected with chlamydia, brought it back to their villages. But look what happened. With no further treatment, by the end of 17 months, up to 30 months, it went away. It was not sustained. They could not maintain it in those communities or in the surrounding communities, such that by 30 months we are at 5, and by 60 months all of these were at 0. So given that Gambia is at the forefront of elimination, these are the last remaining villages, the ecology for chlamydia in that area is such that once you knock it out, it is not coming back. Now look at the difference here. And these are data from the PRET project in Tanzania, where we started with an average of 22% infection. We treated, we got it down to 11. By 1 year, it was at 13. We treated again. It went down to 8. It came back to about 9. We are in now our 3rd round of treatment. There is no way that 1 or even, frankly, 3 rounds of mass treatment is going to be enough in this setting. In fact, data that we have from the entire country in various districts is that we're going to need between 7 and 10 years under program conditions, which is less than 80% coverage in children, before we are anywhere near being able to eliminate disease. But the question here for us is we actually need to determine this trajectory of decline of trachoma infection with multiple rounds. We need to do this in a systematic way, and I think it's a shame that we are 10 years into trachoma control and we're still asking this question. Why? Because programs have not been systematically collecting the data to help us answer this. So one of the questions we asked in PRET, with very high coverage, can we shorten this time? Can we make it shorter than 7 to 10 years? I mean, we only got 8 years left to 2020. And I think that I can convince you that, yes, we can. Here's data from, again, the PRET study, hot off the press, showing that we started with trachoma around 30%. This is 80% to 85% coverage of children. This is 90+%. And you can see it didn't really make it. There's no statistical difference at any point along here. But after 3 rounds, we are now with trachoma below 10% because we pushed that coverage so high. So we're not looking at 7 years. We're probably looking at closer to 4 years, cutting it in half with high coverage. Here's infection, same sort of picture. We were at 22% when we started. We're now down around 4.5% after 3 rounds. And again, 1 or 2 more rounds and we will be done. So I think that, yes, pushing high coverage is critical to shortening that time period. So the other question I asked, well, when can we stop? What about the end game? And does infection reemerge when we stop antibiotic pressure? So I guess sort of like, the dance step, how low is low enough? What level of infection can we have and still say that it's just kind of percolating around, is not going to cause blindness? We really don't know that. What we do know is that if you stop prematurely, it will, of course, come back. And here's that study where trachoma started at a really high level. We treated once. It got down pretty low. We treated again. And then we came back after 3.5 years, and it was already, not to pre-treatment level, mind you, but was already reemerging. And here's some data from UCSF in Ethiopia showing that once they stopped after 24 months of treatment, by 42 months, again, not back to baseline levels, but definitely coming back. So you have to be careful. And here, look at where they were. I mean, this was at 18 months, just right around 0, and yet coming back. Well, maybe these infections are not very robust. Are they capable of being transmitted? And our data suggests that yes, indeed, they are. So if you did not have infection right after treatment, but another member of your household did, you were about 1.6 times as likely to get infection the next time we saw you at 6 months. If that was a relatively large load in your family member, then you were almost 4 times as likely to be infected. So yes, those infections following treatment can lead to transmission. I put this slide in especially for Amy because she loves GIS stuff. This is a way of analyzing the spread of disease through a community. And what you need to know is that at baseline we see lots of clustering of disease within households, within villages. Once you treat, these are kind of sporadic cases that show up, but somewhere between 6 months and 12 months, those sporadic cases have started to infect other households near them. So it takes up to a year before you start seeing that transmission across households again. So annual treatment actually is a pretty good idea to nip this thing in the bud. You might even argue that you should be giving it more often. So we see household spread evident by 6 months post-treatment, across households between 6 months and 1 year. Now, the infection did not return to pre-treatment levels, but if you stop too soon, it does come back. So when can we stop? We now define it as TF less than 5%. But should we be looking at other markers rather than clinical markers? So here is some of the data that you looked at a little bit before. You can see that In a community, people that have no trachoma, about 10% may be positive for chlamydia. They're incubating infection, they just don't have signs. And in about half of the people will have infection, but the other half don't if they have clinical signs of trachoma. Now, after you treat, this separates even further. Very few of people with no trachoma have infection, but of the clinical signs, only about a third will have infection. So monitoring how you're doing with clinical signs can be problematic if you need to, if you think you want to stop. But what are our choices? We can use a PCR test. We take an eye swab, we process it at expense, we get the results. I ship them back to Hopkins because we don't have capabilities in Tanzania. And weeks later, I get a result. So for programs, that's not really very viable. What we need is a specific and highlight, I wish I could put it in red, cheap, rapid test for trachoma. And that way we can decide if we go in and map a village and it's 12% trachoma, is it really got infection underneath that? Do we really have an agent and we need to start mass treatment? And after multiple rounds of treatment, if we're down around 12%, is there still infection? Do we need to keep going with MDA? This would be enormously helpful. So what about some other aspects of treatment? There are questions about using a broad-spectrum antibiotic. What about resistance? You know, we should worry about S. pneumoniae, maybe H. flu. So far, treatment of communities once a year does not seem to be associated with antibiotic resistance. We see transient S. pneumoniae strains that are resistant, but they are very feeble. We don't see clinical cases, and within a few months, the hardier strains that are susceptible repopulate. Adverse events, actually zithromycin treatment's associated with less episodes of diarrhea and fever than using topical tetracycline because it's one of the things you use to cure it. So we don't see a lot of adverse events. What we do know is that the people who are at highest risk for infection are the people least willing or able to pay for treatment. So at one point there was cost recovery discussions about mass drug administration, and that would actually completely ruin a program because the ones you need to get to, you would not be able to. So here we are, back at our slide. We've talked about surgery, we've talked about drug therapy. Let's talk about F&E. Well, if we have an effective antibiotic, why do we need sort of face washing and environmental improvement with such an effective antibiotic? Well, two things I would remind you. One is, think of the story of Ellis Island back in the early 1900s, where trachoma was a real big problem in New York. In fact, for those of you from New York, Bellevue Hospital was originally a trachoma hospital. Moorfields in London was originally a trachoma hospital. And it disappeared before antibiotics. Why? Because of socioeconomic status development. What aspect of it that happened, we don't know, because it was so massive. People put in roads, they cleaned up the horses, automobiles came in, housing was better, water came in, latrines came in, everything happened, and trachoma disappeared. So we know it can disappear for good without an antibiotic. And here is the worry, that you have an effective antibiotic, you decrease infection, and then at some point you stop and it comes back. You treat it again and it's gone, and you come back and you just end up in this cycle. Have we seen this before? Yes, we have. Morocco, which has declared itself free of trachoma, also declared itself free of trachoma in 1957, and it came back in the 1960s and went through another round. So yeah, we have anxieties about what happens when you remove antibiotic pressure. But we also know that chlamydia is an infectious disease. So there is a cycle of transmission. There is a equilibrium point between transmission and susceptibles. such that if you change that equilibrium point with improved hygiene and environment, you will get to the point where it's just not sustainable anymore. Now, we don't know what that point is, but that is why we insist on having the F&E as part of the entire strategy for trachoma to try to reset that point so it doesn't reemerge. Well, I said I would talk about a vaccine, and I'm only going to talk a little bit about it. There have been claims for a vaccine for chlamydia as long as I have been in this field, and everybody gets excited about every 3 years or so saying they've got a really good candidate, and then they try it out and it's a disaster. It's very difficult to develop a vaccine for an infection that you can get over and over again. And particularly this one, where you want to elicit an immune protective response and not an immunopathologic response, because that's what trachoma is. Those follicles, that scarring, is the immunopathologic response to the organism. And if you elicit that, as they did with the early vaccines for chlamydia, then you've actually done more harm than good. The problem that, as I pointed out here, is that vaccines may not prevent primary infection, but the goal is to actually reduce the sequelae of getting the infection over and over again. So Harlan Caldwell from the Rocky Mountain Lab published last year work that actually is relatively exciting. He's developed a live attenuated vaccine. He's inoculated it using non-human primates, and he observed less disease and a shorter infection period in them. But the interesting thing was when he did repeated infections with this attenuated strain, there was no pathologic response at all. So 2 things here. It suggested that the plasmid, because these were plasmid deficient, is what sustains the persistent infection with chlamydia. And the other thing he noted was that there was 50% protection against a virulent challenge. That meant they got no ocular pathology. The rest did, but at least 50% did not get any ocular pathology. Still some work to do, but for the first time we're seeing that maybe they get infection, but they don't get the pathology with it. Now there were some differences among the monkeys that still have to be sorted out, but this is about as far as we are with a chlamydia vaccine. I would also add that we've got another problem, and that is that almost all this work is supported by funds for chlamydia vaccine for STDs. So like the HPV vaccine, when do you give that? You give that in, presumably children when they're 10, 11, 12. But for trachoma, you've got to give this to infants. You've got to give it to them early before they set up, before they get it, before they clear it. So you're talking about having to figure out a vaccine that will work in babies, or at least by age 1. And that's going to be a real challenge to get that vaccine tested in that age group. So what do we need? What are our urgent needs, our challenges? For surgery, we need to figure out how to improve surgery. Without that, we're not going to meet that goal of eliminating the backlog of trichiasis. And we need to know how long after we get rid of active trachoma we're going to need to keep that surgical program going. One of the things we see, for example, in Gambia, which has basically eliminated active trachoma now, is that surgery cases keep coming up. Why? Because these are the people that were exposed long ago, and they are still developing those interned lashes. Their scarring process, for whatever reason, is still ongoing. And how long do we need to plan for that? For antibiotic, we need to determine the trajectory for elimination and figure out markers of when we can stop mass drug administration. We are now in a position where the Carter Center, for example, has been treating in Ethiopia for 5 years. They are getting donor fatigue, and yet they've gone from 50% trachoma to about 30% trachoma. They want to know, maybe there's no infection there. Well, I can guarantee them there is infection there. But they want to know when they can stop. And that if we don't use clinical disease, what else have we got? And then for F&E, we need more ethnographic work on community involvement, on how to improve community participation in face washing programs and improving environment. We talked a lot about that kind of informally today about the trials of working to improve hygienic conditions in some of these environments and choices that people make. All right, so where are we? Elimination of blinding trachoma by 2020. Success. Well, we're already down from the second leading cause of blindness. We're down about sixth now. I guess that's kind of success. We've got many countries that are poised to apply for certification of elimination. Mexico, Oman, Morocco, again, Ghana, the Gambia. We've got more partners coming on board. DFID has announced a major effort to work on trachoma, so all of that is good news. We still have challenges in our programs, countries that still need mapping. What are we going to do about Afghanistan? I mean, there was trachoma there. That's a big problem. Nobody wants to go run around and do mapping because there's too many landmines. Can't blame them for that. Conflict and post-conflict countries, we don't know anything about trachoma in Congo, and not a lot of volunteers wanting to go out and do mapping there. Guidelines from WHO specify surgical criteria that are going to be very difficult to meet, sub-district criteria for elimination of active trachoma. Doing all those surveys at a sub-district level, it's going to be a real challenge. We are going to be facing program fatigue, which actually the programs have been reinvigorated now that there is harmony with some of the neglected tropical disease programs like Schisto and LF. So yes, we've got challenges, but I think the successes that we're enjoying here, the research we've already done and the partners coming on board are testimony to a continued and renewed effort that while we may not succeed in every single country on the planet, we're going to go a long way to making sure that trachoma is not even among the public health causes of blindness by the time 2020 rolls around. So I thank you for your attention, and I thank you again for inviting me to speak. It's been a real pleasure. That's actually a good question. Humans are the only host for chlamydia, and we wondered about that. So we did some work, and believe me, you haven't lived if you haven't tried to take an eye swab from a cow, and there's no chlamydia, and there's no known animal reservoir for chlamydia, except I think there's a marsupial in Australia that is being used as an animal model. Or no, yeah, I think that's right. But in these countries. However, having said that, of course, there is the concern about flies and the fact that, at least in many of these countries, there are a species of fly that are eye-seeking flies that go to the eyes for protein and for moisture. And in a pretty disgusting and not good conversation pre-dinner, will suck up ocular contents and regurgitate them in other eyes as they make their way around the room, and are thought to be one mechanism of transmission, although no one has ever successfully studied whether or not you get an effective dose from a fly, but certainly you can trace that fly hopping around from eyes to eyes. So there's been some effort at trying to control flies in the environment as one way to reduce transmission, which clearly takes place using a number of different sources, from towels and sheets and hands and clothes and things like that, but no animal reservoir.
Not everybody's infected. Is there some natural immunity that people have?
There is clearly a partial immunity that develops in adolescence and into adulthood. Doesn't mean that they won't get infected again if exposed, but it's both a combination of what we think is some immunity, so that if you get a low dose, you don't mount a clinical infection. But it's also the fact that you're not sitting in this sea of transmission with all these little kids sharing ocular secretions. That older kids and adults are largely out of that pool of transmission, which is why we don't see active trachoma in the older ages. But there is some, what we think of as kind of partial immunity from getting it over and over again in adults, but clearly they still do. This mother I've got up here, we could still find infection with her, in her, possibly from just all of her child care activities.
I wonder if you could say a little more about the lack of acceptance of surgery and treatment, and what exactly you're planning to do to address that.
Yeah, that's a real significant issue. And we just, as part of our Gates grant, completed a study on surgery in Tanzania, trying to see if this new surgical device that we developed would benefit. And we had trouble recruiting because people just just didn't want to come in for surgery. And one of the people working on the project developed a simple information sheet that said, here's what you can expect to happen when you walk in the door. Here's what it's going to look like. Here's how it's going to get better. And here are the benefits from it. Honestly, it was a one-page sheet that people talked with, and after that we had no trouble recruiting. Now that was just in one area, and I was thinking to myself after that, and that was just last year, that maybe the real issue is just imparting the knowledge that the way that patients are handled in these environments is you just don't tell them anything. And they go back to their village with this hugely swollen eye that's got, eyelashes pointing up to the ceiling until it actually heals. And that instills a lot of fear. So, the plan is two-pronged going forward. I mean, one is to take advantage of that educational tool and work with partners to see if implementing that would improve surgical uptake. And the other is to figure out how to get in program hands the recurrence rate down. Because to my way of thinking, if people are making rational choices, if they're saying, let's see, in a year, I've got a 1 in 2 chance that this is going to come back, and when it does come back, the surgery is going to be even more difficult. I don't know. Maybe I'll just pull out my eyelashes. So until we can, in program hands, really improve surgery, and I think that has to be done with a lot more stringent training and certification, then I think we can be in a position of saying, yeah, we recommend surgery for you because your chance goes down to, 1 in 20 that you're going to get recurrence.
What exactly is done in surgery?
So let's go back up, because you might find this interesting. Then again, you might not. Interests me anyway. Let's go back up to this eyelid that has trichiasis up here. Hang on. It's going to show up any minute. There we go. Here we are. So you can see that this woman is looking straight on, and you can see that her eyelashes are not up here where normal people's eyelashes. They've been turned under. They're actually coming out from underneath the eyelash. So what you do is put a clamp here, and make a full thickness cut and rotate that eyelash up and stitch it back up. So the eyelashes, instead of down here, are rotated back up. And then you keep the stitches in, let that wound heal, and the eyelashes are rotated back up off the cornea. Now, and that's the ideal for this. In the meantime, of course, you've got a lot of wound healing going on. It's very swollen. Some part of the upper eyelid is exposed just because you've got an over-rotation at that point. But if you've done it well, then you've got a nice, clean eyelid margin again. The success of the surgery depends on how many of these eyelashes are rotated under. Some of the cases are so severe that you actually look at these patients, you can't even see any eyelashes. They're all underneath there. And those are really hard cases to operate on. The outcome of that is much harder to predict. But that's what's involved. Yep.
Are you sedated during the surgery?
They are given a local injection. So you put in a local anesthetic. You've got a needle. This doesn't sound very good, I know. It goes, you push the anesthetic ahead of you along this eyelid to numb it. And then it creates a big bubble of this anesthetic, and you let it sit there long enough so the eye is numb. And then you use, ideally, you have these clamps and then a plate, a lid plate that protects the cornea as you make that cut. And at that point, patients don't feel anything, and they don't see anything at that point because you've got a big clamp up there. So, I mean, you would have to sedate me, let's put it that way, but they seem to be all right with local. Yeah.
I was just wondering, did you see any differences between men and women in terms of like the severity of the frequency?
You know, that is a really, really good question. To me, I've always wondered, why is it that when you go into a community and you look at kids and you see active disease, they're almost equal. Maybe a slight excess in the girls, but most of the time it's pretty near the same in terms of active trachoma. But the scarring complications and the trichiasis complications are 4 times higher in women. And we have no good explanation for that. Although I was talking earlier today with an immunologist who was studying placental malaria and some of the issues in the response of pregnancy to malarial antigen. And I was thinking, geez, maybe we're missing something here that we never even really thought of, looking at differences in the response to chlamydia. There's no a priori reason to think, apart from pregnancy, that that men and women respond differently, but honestly, nobody's looked. So there's, I think, some real opportunity here. I'd be excited.
Good question.
Yes, that's another good question. So most of the work that's been done on nutrition in children hasn't found any particular relationship of kids who have trachoma and don't, and markers of acute malnutrition. However, there was some work done in Ethiopia to suggest that markers of chronic nutrition were more common in children with trachoma compared to children without, within the same community. However, what we know is that trachoma clusters, and it is in the poorest of the poor, even within community settings. So whether that's just a marker for the kids who are more likely to get trachoma, or whether there's some synergy there, we don't really know. So that's the summary of where we are today with understanding nutrition and trachoma.
Okay, let's go next door to Deputy Hall, and thank you very much.